source material, but someone then made the observation that I've got the first few objectives are over those. So I am not going to write ClinMed questions, okay? But I may write a question, you've seen these before, where I'll say patient comes in, they've got these complaints, or they're diagnosed with this. So it's more for you to have context within a potential assessment question. Okay, but I am not going to write a question for ClinMed. Okay, so starting on page 12, so steroids, you've seen them. If there's any set of drugs that you know any better when you get out of here besides non-steroidals, it'll be steroids, because we talk about them a lot. They're great anti-inflammatory and immunosuppressants. So again, we're going to use them for immune modulation. We are also going to use them only for induction of remission, just like we did with RA. Remember, we only did it, or we used them as bridges until the other drugs, remember the immunosuppressants, how long did they take in RA to actually have an effect? 6 months. 3 to 6 months. So a long time. So we're going to do the same thing with the steroids, is we're going to use them for short periods of time to get them into remission, or we may use them a bridge until we have to use more potent immunosuppressants in more severe disease. And the reason we don't want to use them for chronic use is the side effects, and they're listed there. You should be, I'm telling you, be able to rattle those off in your head. With steroids. So the HPA axis, suppression, infection risk, immunosuppression, high glucose, high blood pressure, weight gain, white blood cell count going up, edema, alteration of moods, insomnia, osteoporosis. Those ought to be emblazed on your brain, okay? In terms of the drugs themselves, you can see mostly what I'm after is that you know that there are different formulations. So you see hydrocortisone comes, we use it here. We're not going to use that as an oral agent. We would use prednisone if we were going to use an oral steroid. So this is mostly going to be enema or foams. And again, they're only going to be used for the more milder or the very limited disease of proctitis or in the sigmoid colon. If you look down after prednisone, and you'll see those are for ulcerative colitis, because Crohn's is not usually going to be a problem for us in the gut, or in the colon, sorry, even though it could be. Then you see two others, budesonide in 2 new formulations. So there you see controlled ileal release. Intacort is a brand name, and that is only for Crohn's. It's formulated to not dissolve until it gets to the ileum. And then you see budesonide IMID-X, it's a multi-matrix is what that stands for. And again, it is a drug that is not designed to dissolve until the large colon. We have very few drugs that will do this. This is targeted delivery. It's all that pharmaceutical knowledge that those chemists have, and the technology they put together to get a drug not to release until it gets to a certain place. Okay. So budesonide, which we used it for asthma. We have an inhaler, Pulmicort. We use it in we can use it in a nebulizer and nebulize kids that have got asthma. So here we've got it now. We can use it orally. So you'll see that in some places when we talk about it, if we've got somebody who needs a steroid, we may use this. They don't respond to the salamine or the topical products like we wanted, so we put them on an oral. So in some places you'll see where it recommends go to this first. Usually you can leave them on it up to 6 months, then you're going to transition them to something else. So we would never treat anybody with this long term. The longest term would be that 6 months. And that would be for more severe, more pancolitis, or when we get into Crohn's for the other drug. Some systemic absorption still occurs, so they can still get side effects if you use it too long, but much, much, much less effective than what you see if you used oral prednisone. In Crohn's, you'll see some places where it will say use prednisone first. And if that doesn't work or they can't tolerate it, then go to one of these other products. And then I think it's in UC, we'll see that they'll recommend if you have to go to a steroid, you use this first. These are expensive. Prednisone is dirt cheap. So there'll always be a weighing of in terms of cost for some folks as well. Okay, questions about the steroids? You've seen it all before except those two new drugs. If you look on page 13, these are the immunosuppressants. You know these drugs, you have seen them before. Look at the bottom. Azathioprine, 6-mercaptopurine, immunosuppressants we've looked at before. Cyclosporin, immunosuppressant we use a lot in transplant patients to suppress the immune response. And then methotrexate, a non-biologic DMARD. Here, it is not the first choice like we saw with RA. It's after others have been tried or used. Again, with these drugs, they're going to be used as augmentation. So you're not going to see these until you get into very severe disease or disease that will not respond to usual methods. So these folks have already gone through mesalamine, they've gone through a steroid in some fashion. They are usually steroid dependent. You can't get them all the way weaned off, so you will put these on, you'll put on an immunosuppressant to either greatly decrease the amount of steroid they need, or you will transition them to this. People who have, they could have, I don't know if they could have mild, but let's say they have more moderate or severe disease, but they have multiple flares. So the usual course is going to be newly diagnosed in a flare, you treat that, get them to remission, put them on maintenance. They will have flares on top of that maintenance, just like we saw with RA. Okay? So you're going to treat those flares just like you did in the beginning. If people have multiple flares and you're having to use steroids with those, then they will move towards these immunosuppressants or the biologic DMARDs. Okay? You have seen all of this before. Long-term use, they're not going to provide acute relief, so you're only going to see them as maintenance meds. You know that they are steroid sparing, meaning you can greatly reduce the amount of steroid. You also know that it takes months for them to exert an effect. So if you have to use them, you'd have to bridge with other anti-inflammatory or immune modulators until they take place. You've seen that all before. The type of side effects, you've seen them all before. So the big things with immunosuppressants is that your infection rate can go up, severe infections, you can activate TB or other infections that are smoldering, and your malignancies, and your myelosuppressant. Everything you've seen before, you just have to reactivate it in your brain. And that's about it. I just want you to be able to recognize them. We're not going to spend a lot of time in terms of treatment with them, just knowing their place. There are 2 antibiotics that are used in Crohn's. You'll see that they are the second step. They're first line, but you try the mesalamine. If it doesn't work, you go right to an antibiotic. With UC, you won't see them until you have to hospitalize someone. So the 2 that are used are ciprofloxacin and metronidazole together. Great gram-negative coverage, great anaerobe coverage. That's why they're there. Okay. That's about all I'm going to say about those. We'll talk about a little bit more in context, but just want you to know that those are the 2 go-tos in these diseases. The TNF alphas are going to be more in stage. Now, in your lifetime, you may see them move up. You know, as we get ones that are tolerated, not as toxic. I think you're going to see major changes in these biologics in the next 20 to 30 years. The ones that are used, if you look at the bottom, are infliximab, which is Remicade, Humira or Adalimumab, and certolizumab or Cimzia. Remicade or infliximab has been the one that is talked about the most. It's got more history. The drug's been around a long time. Has more side effects and it's a little bit harder to use. So I think you will see in practice much more of the Humira used. So all of those three have data behind them to support their use. The last one on page 15, these are the anti-integrin antibodies. These are pool drugs, very expensive. You're not going to see them. I've never seen them used. But they are more for advanced Crohn's. Just want you to know that, that they're out there and available. So natalizumab and vedolizumab. So the Zumab, that's all you have to know, is remember, they're going to be a biologic of some kind, monoclonal antibody. Okay, that's the drugs, so that's what I want you to know about them. Now we're going to put them in place and look at how they appear in the treatment of these two diseases. Okay. So let's start off with mild to moderate active disease for ulcerative colitis. So this is going to be proctitis or proctosigmoiditis. I took the next, let's see. The next 3 pages are summarized in this table that I gave you. So it gives you, across the top, it gives you mild to moderate local, mild to moderate distal or pancolitis, and then severe fulminant and fulminant. What I'm going to test you over is going to be the mild and moderate. I'm not going to test you over the severe to fulminant. Those are going to be really specialized, or they're going to be hospitalized very ill people. Not that I don't think you can do it, but the majority of people, 70% of people who have UC or Crohn's are going to have the more mild to moderate. That's what you're going to see. Most of the time, these people are going to be diagnosed by a GI specialist, and then a lot of their care may fall to you, especially if they're in the mild to moderate disease range. So there is really nothing new on here, it's just in a different form. All right. So when we're talking about proctitis or sigmoiditis, we're just in this part of the gut, okay, right at the end. So it's going to be topical use that we're going to look at. So we're going to use the mesalamine. It's a really good drug that will induce remission pretty fast. So suppositories, enemas, foams. So this is usually just a topical use. They're really good at inducing remission. You'll see down there greater than 90% of people will go into remission, and if they have to keep taking the drug, it will sustain a remission as well. Quicker relief with these agents than oral agents. So that's the plus we talked about early on. And mesalamine is superior to a steroid in this setting. The enemas, the foam suppositories are just a review. So we're going to start with one or the other, depending on where the problem is. If they do not respond, if you go down to the third big black bullet, if they don't respond to the topical mesalamine, you can use a combination of a 5-ASA and a steroid. Here they usually like to go with the foam. If they can't tolerate those, then you can switch to a steroid suppository or steroid foam. If they can't tolerate that, then the last would be to go to an oral agent. So what can you expect? You can expect that their symptoms are going to improve. Their constitutional symptoms, are, if they have any, are going to resolve. The bleeding, the stooling are going to resolve and go back to their normal. It takes about 6 to 8 weeks for the gut to recover. So with that, we're going to consider our induction time. Once we're past that point, then we're going to start a taper. And we will taper them with the point of discontinuing them, especially if they are just proctitis. So the majority of people who have mild or moderate localized UC, their flares are rare. So if they only have a flare a year, we're not going to put them on maintenance meds. So the people that we're going to maintain are going to be those that relapse frequently, with proctitis, but for most part, if they have flares that are long-term in between, we're just going to treat them acutely. Okay. If they start having relapses that are closer together or more severe symptoms, then we will put them on maintenance. Okay. So proctitis, first flare, you just treat the initial and then you taper them off. Okay. And you just treat the flares if they're long-term between. Frequent flares, then you would put them on maintenance. For all patients who have proctosigmoid colitis, those people they put on maintenance because you've got more of the gut that is maintained or that is affected. Got that? Okay. You can use topicals, you could use orals. So if they use topicals, they usually can go down on the number, or maybe to just one form. If you're talking about just proctitis, they would use suppositories. If they are sigmoid, then they're going to use the foam more often. Or they could use a combination. There's, if you're not familiar, if you've never seen an enema, there's how it's usually come. Here's the foam. It has an applicator that they fill, and then they depress the sides there to deliver the drug. And these are just squeeze bottles. Let's see the rest. Here's mesalamine, which is a enema form as well. Shows you the. So let's look at mild to moderate where you've got more distal disease. So here, in addition to what you've already known to use, you would add an oral agent. So once you're past, you've got the transverse colon in the right side, then you have to use an oral agent. So here the combination is oral mesalamine plus either a mesalamine or a steroid suppository and a steroid enema or foam, all three. High remission rate, high response rate, very effective. Really, all the mesalamine products are considered to be equally effective. In terms of response, 2 to 4 weeks of response, a little bit longer than what you would see with the other group, and then 40 to 80% of patients respond, so a little bit less than we saw with those that had mild. If they have inadequate response, then the next step would be to add the budesonide MMX, or Uceris, sorry. So then you can use that because you don't need an oral steroid to blow them out, but you can go to oral prednisone if they can't tolerate that or don't respond. These folks would be maintained then on maintenance therapy. And it would be, again, oral therapy would be their base because it's pancolitis or larger involvement, and then you put intermittent for symptoms with the either the suppositories or the enemas. Make sense? Okay, questions? Okay, severe disease. So it's where you just keep adding. So you're having to go more powerful. So here you're going to use oral steroids to help settle down the gut. And you're still going to use your oral ASAs, or 5-ASA, your suppositories, and your enemas, all of them, to help bring about a remission. You would discontinue, if you look down the list there, so you want to take away drugs that are going to slow the gut down. Because these people will have what we call tenesmus. It's that feeling that I have to go, that straining, that I just can't seem to move bowels. Very painful and uncomfortable. So to try and take that away, that urging, that sense of urging, you would want to take drugs away that are going to slow down or impair the gut. IV antibiotics may be used here, so your ciprofloxacin, your metronidazole would be the two drugs you would go to first. Bowel rest is not recommended unless they're having such frequent urges to defecate, then to make them more comfortable, you can do that for a period of time. Nutritional support. So here's where if you've got somebody that this is a long-term problem and they're malnourished, this is where the enteral feeds could come. So enteral feeds are usually delivered down a tube. So we drop an NG tube and we deliver the enteral feeds into the gut, or well, stomach. We usually don't do parenteral for these folks. And again, it's that short chain fatty acids is really important for the gut health, and so we want them to continue to get that for its metabolism and nutrition. If they don't respond, then this is time for hospitalization with these folks if they have not already been hospitalized. The one thing I want you to note in there, it's the one thing I have pulled out of fulminant and severe that I want you to know. These people, for some reason, are at much higher risk to have a clot than others. And it's even if you don't hospitalize them, their clot risk can go up. So, but when they are put at bed rest and we hospitalize them, it is recommended that they receive prophylactic heparin. This is for UC and for Crohn's. I was also asked about why I highlighted these different words. I did it so that they'll stand out because there's just too much verbiage. There's not enough pictures. So it's to break it up and also to draw your attention to the most important of the words that are there or the drugs that are being used. It doesn't necessarily mean that I'll take a test question from that. So my test questions will come from the objectives. And it's pretty. So that's why it's there. It's mostly just so you can find the drugs for the most part. The other is that you now start to see at the bottom of the page that term steroid refractory start to show up. So that usually they are using that when they have used short-term steroids to affect a remission and they can't achieve it. So that's what it's steroid refractory here. So think about it in asthma. We talked about people who are steroid refractory. We could not get their airways to calm down enough so that they could go off the steroids altogether, right? Okay. We did the same thing in rheumatoid arthritis. Sometimes when we bridged those folks, we got them onto an immunosuppressant, they couldn't entirely come off the steroid without having flares or frequent flares. Okay? Same thing here. So that's what that steroid refractory means. So they're applying the same term here. So with these folks, they may go to cyclosporin, but I can tell you cyclosporin is such a it's like, you know those guns of Navarone that I told you about a long time ago? These are like big cannon drugs to suppress the immune system. We never use it, we wouldn't use it here long term, but we might use it to induce remission. And then we would transition them to something else. So it could be a biologic, so those TNF alphas could be the transition. But cyclosporin will do it quickly if we can't achieve it by other means. But it's a H-bone of immunosuppressant. Okay, maintenance on the top of page 17. So if we've had to use IV steroids, let's say a person's NPO, we don't want to give them anything, or we want to make sure that we're not having to deal with a lot of inability to absorb a drug. We've got lots of disruption going on in the gut, so we're going to give them IV instead. If you use an IV steroid in these situations, then we try to use it for a short period of time. I put down 3 to 5 days. By then, if we've got their gut settled down, we would switch them to PO. And we're going to use the same approach that we've used in other diseases. We're going to stabilize them, like we talked in Durham. We're going to stabilize the disease process, and then we're going to do a slow taper. And in these people, they do a really slow taper, months of tapering them off. If you rapidly taper them, usually you'll get a flare, just like we've seen in other diseases. So same thing holds true here. For people who continue to relapse, especially as you're taking them off steroid, those are termed steroid dependent. That can be due to the flares they get when you're trying to remove the steroid, or you can't get them to a very low dose. And here they give you can't get them below 10 milligrams a day. 5 is considered about physiologic. So above that, you're giving the person more than they would produce themselves on their own. So those that continue to be steroid dependent, they have frequent relapses, or they require more steroids when they relapse, then those people are ones you would move to immunosuppressants. Fulminant disease, these are the sickest of the patients. They are the ones that usually are going to have emergency surgery. They're at high risk for toxic megacolon. They are usually, if you look down there in terms, or look back on the chart where we've got the different stages of severity, these people are having frequent stools. They've lost a lot of blood. These would be the ones that would require transfusions. They could be malnourished depending on how long it's been going on. They have life-threatening complications, that toxic megacolon or perforation, bowel perforation. So if they can't be stabilized fairly quickly, and they have a time period of about 72 hours, then these folks could undergo a total colectomy. Or if they have maybe they respond, but you don't get a full response, then they could also undergo a colectomy within about a week. I am not going to test you over the fulminant disease, but here's just for your information. Okay, questions about UC? Crohn's disease. And again, we're just going to look at mild to moderate. So usually this is distal ileum and right colon. Usually these folks are more symptomatic. Oh, I know. Let's do this. I brought some cases. It looks like we're going to have time to. Let's look at this person. So go back and get your charts out so you can look at it. So this is a 23-year-old white female. So she hits about the time period, maybe a little bit older for these diseases to show up, but she's a young woman. She comes into the ER complaining of abdominal cramping, increased stool frequency of 5 to 6 a day for the last week with some bright red blood. She notes a 10-pound weight loss and anorexia for 2 months. She's got a past history of being hypothyroid, chronic headaches. Her medications are the NuvaRing, which is what?
Birth control.
Right, so it's a combination product? Levothyroxine, 150, what's that for?
Thyroid.
Thyroid. Naproxen, what's that for?
Headache.
So she has a family history of inflammatory bowel disease, colorectal cancer. She's allergic to morphine and allergic to sulfonamides. She drinks some, no tobacco, anxious, mild distress, tired appearing. Blood pressure is 100/70, is that normal?
Yeah.
A little bit on the low side. Pulse is 90, is that normal?
No.
It is, but high end of the range. Temperature is 99, is that normal?
Yeah, sort of.
Slightly high. 60, so she's 5'6", she weighs 65 kilos. Skin is dry, poor skin turgor, so what are you thinking? Some dehydration. Do her vital signs go along with that? Slightly, so she's a little bit, she's not hypotensive, but she's a little bit on the low side. Her heart rate's a little bit on the high side. Could be just the anxiety of seeing you. Abdomen soft, distended abdomen, left lower quadrant tenderness on palpation, rectal guaiac is positive. What's that mean? Blood stool. White blood cell count is 4.5. Is that normal? Abnormal? Pardon? Normal. What's normal range usually? 4 to 10, 12, depends on your lab. ESR is 25, is that normal, abnormal? It's a little elevated, It's on the lower end, it's elevated. Albumin is 3.4, is that high, low, normal? It's the low end of normal. It could be abnormal, depends on the lab. Hematocrit is 40, so what's her hemoglobin?
Divided by 3. 13.
Okay, so for a
What,
female, is that
33?
normal, abnormal? Normal. So imaging, she has a colonoscopy, it's indicative of inflammatory bowel disease, extends from rectum to the splenic flexure in a continuous distribution. Abdominal x-ray is negative for colonic dilatation. So what is her pattern most consistent with? UC or Crohn's? UC, why is that? Location, continuous. She doesn't have a lot of constitutional symptoms. She does have that weight loss, which is a little bit. Family history, okay. Anything else that's consistent? What about what is the severity level? Look at your chart. She mild, moderate, severe. Look at the one in what page? 5. So what's her stool? What's she reporting?
5 to 6.
5 or 6. Does she have blood?
Yeah.
Yes. Minimal systemic. Normal ESR. So where is she?
Moderate.
Moderate. Does the clinical picture reflect that? Pretty much. Okay. So what are your options in terms of treatment?
You can't do sulfasalazine.
Can't do sulfasalazine because why?
She's allergic.
She's sulfonamide allergic. So what are your options? You have the salamine and what's your goal? What are you trying to do? Induce remission. So you have to use drugs that act quickly. So what are the two we would use? Okay, so mesalamine or steroids? Which way do we go? Mesalamine. So because she's got rectal, sigmoid, and left-sided colon, what kinds of dosage forms are we going to use? So an enema. We could use also suppositories. So that would be our first approach. What if she couldn't tolerate those or refused to use them? What would we do? We could do oral. Wouldn't give her as quick a response. What would we expect to resolve first? What should we expect to see if she's responding to therapy?
Decrease the number of stools.
Decrease the number of stools. What else?
Blood.
Blood should go away.
Discomfort.
Pain.
Her discomfort, the other symptoms she's having, hopefully we can start to get her back on to eating. I would involve a dietitian and help her to figure out what kind of diet to put back together for health and tolerance. Okay. These are the type of questions I would ask you. If you're sitting there lost, then you can always come see me. But those are kinds of the things that I would expect you to know. Okay. Anything else about her case? Okay, so remember with Crohn's, we've got constitutional symptoms are common. We have a discontinuous distribution. Those mouth ulcers, extra intestinal complications or manifestations are more common. Usually not the colon, can be, but less common. Ileum involvement, most common. Strictures, fistulas, transmural, the whole wall, and crypt abscesses and that cobblestone appearance are the hallmarks of Crohn's. So more likely they're going to come in with the abdominal pain, bloody diarrhea, fever, weight loss. So first line here is the slow release 5-ASA products. So Pentasa and Asacol are more commonly used here than you would see the other 5-ASA agents. If they do not tolerate them or they do not respond, then the next step they go to are the antibiotics. So they'll go to metronidazole and Cipro. This is kind of evolved through just what people do. So there aren't a lot of studies behind it to support it, but what they think is that there's either an infectious agent that is contributing, or you've got microperforations that are leading to the more constitutional symptoms. So that's the second step. So different than what we saw with ulcerative colitis. Here, if they're unresponsive to those measures, then they recommended going to oral steroids. Here, the convention would be to go to prednisone. If they don't respond to prednisone, then going to the budesonide CIR. The CIR would be the next, and that's listed under that third bullet. So steroid alternative. So note those differences. So in ulcerative colitis, we saw going to budesonide before oral prednisone. Here, it's oral prednisone and then the budesonide CIR. Only used to induce remission. So same thing, we're going to induce remission and then try to maintain that. The adjunctive measures are a little bit different. So here, you would offer them, the diarrhea tends to be more prominent and also occurs more frequently. So antidiarrheal medicines like loperamide could be used. Bile acid binding, these are the drugs that we used for lipid lowering. So cholesterol, equestrian, cholestyramine. So these drugs, one of their side effects is constipation. So what they do is they bind bile acids and they keep them from being reabsorbed out of the gut. And so they will stay there and they're binders. So they'll make a stool much more hard and firm. Probiotics. Talk about these when we get to nutrition, but probiotics are kind of the fad, universal, cure everything. And there is a lot of reason to think that perhaps those drugs would be, or those supplements would be effective, because we believe now that the changing the gut biome or the environment of the gut is pro-inflammatory. That if we have done that through the foods that we eat, the additives that we have, that we've changed that, then there is good reason to think that if we can restore the gut biome to normal, then people's symptoms would go away or their diseases would also be ameliorated. There isn't a lot of data though. And the other is that they are supplements. So how are supplements regulated in this country?
They're not.
They're not. So the FDA has to approve them, but there isn't the data that has to be to show that they do exactly what they said. They have to be safe. But efficacy, they don't have the same burden of proof that medications do. Okay? So that means there could be wide variance. They also have to be pretty much used on a regular basis, so just taking them here and there doesn't probably do the job. The others are expensive. You ever priced them? They're really expensive. So anyway, but they're probably not going to hurt, and they may help. Lactose avoidance, so that again is a common gut irritant in our society with large groups of ethnic groups that have trouble with that. So avoiding lactose containing, so that's going to be mostly dairy, and then other food triggers as needed. I would certainly have a dietitian if you have can have where you can refer to one, use them. Because this is a difficult disease for these folks to deal with. The more nutrition, the better their nutrition status, the better they're going to respond to therapy. On the next page, top of page 19, we're almost done. Again, we're going to probably, if we can get them into remission, is keep them there. We'll still use the oral acetaminophen products. For those with, and that's pretty much the mild to moderate, where you can use that budesonide again, but you're gonna use it for limited times and taper them off. For the severe and refractory, these folks are usually admitted to the hospital, they require bowel rest, they may require surgery. These folks will move to the more powerful drugs faster, so immunosuppressants, the TNF alphas, may be used much more early in disease than what we saw with UC. The anti-integrin antibodies can also be used, but they are usually last line for inflammation. And then surgery with limited resections is also a possibility. On the next page, that little algorithm is for Crohn's. Questions about inflammatory bowel disease? A lot of it's encouragement, adherence, and being aggressive with therapy and then keeping them in remission. Okay, I will see you on Monday. The reason I put the test at 11 was this. I have followed Dr. Bonetta before. Don't take this. Don't take it.